All right, to go ahead and end the first session today, I have a question that I want to first ask. Has anyone ever felt frustrated by long delays for medical appointments? Now imagine finding blood in your urine and having to wait 3 months to check for bladder cancer. That's a problem our project, Optimized Cystoscopy, led by Dr. Vij, Dr. Alambeigi, and Mohammed, set out to solve. I'm Hannah Choi, and with my fellow health associates, Manal and Zoha, we conducted competitive landscape research and identified a key gap, that automation exists only for complex post-cancer cases, but not for diagnostic cystoscopy. This work showed us how a robotics concept evolves from the lab into market strategy and highlighted the importance of asking sharp questions from the user's perspective. Our mentors helped shape our strategy. Alyssa Maldonado-Holmhertz on regulatory integration, Ashley Pippin on clinician validation and remote scanning, and Arturo Pena on value proposition. Together, we're shaping our vision, every cystoscopy, fast, accurate, accessible. Now I'd like to hand it off to Dr. Vij.
All right, thank you, Hannah, for that introduction and for all of your guys' help with this. I'm Dr. Sarah Vij. I'm a urologist here in the Department of Surgery. So as Hannah mentioned, imagine you see blood in your urine. You get in to see your doctor. They inform you that the next step is to place a tiny camera inside the urethra in the bladder in the office to look for a bladder tumor, among other things. And they tell you the next available appointment is 3 months. That's hard to stomach. So about 1 million diagnostic cystoscopies are performed annually in the United States, and this procedure detects bladder tumors, among other things. Bladder cancer is a highly morbid cancer that can grow and spread quickly, so time is critical. Access to this office procedure can create a huge bottleneck, as the average wait times, according to the data, is about 4 to 12 weeks, or 1 to 3 months. And due to limited steerability and poor ergonomics of our existing scopes, it can be difficult to visualize the bladder, leading to about a 10% tumor miss rate. And additionally, these procedures are performed by urologists, and with our aging population, we are not training enough urologists, and availability to get this procedure is limited. So we present a solution. That attaches to our existing cystoscopes that are widely used by all urologists. This is one of them here. We're not recreating the scope. This is an attachment that will go on existing cystoscopes. And what it will do is robotize the scope such that the operator can manually control the scope using something like a remote control that looks familiar to all of us from video games. These images can then be sent electronically to a urologist, whether they are on site or off-site, so that helps populations that are underserved and have intermittent access to urologists. We'll have a lower tumor miss rate and improved procedure and improved success rates. The markets for cystoscopy is huge, and it's growing. It's thought to reach about almost $2 billion by 2033. There's definitely a market for this procedure, but unfortunately, access to the proceduralist is not growing at the same rate. Our experienced mentors, as Hannah went over, guided us through various stages of our proposal to ensure that we have a path to market, and we're very grateful for all of their insight. One additional benefit to our solution is that this can be operated by a nurse or a medical assistant. It can take the urologist out of the mix for the procedure, freeing up the urologist to do higher complex care, whether it's in the office or in the operating room, potentially freeing up 2 hours per day for those providers. Our path to patients, I've shown here. We are early in the process, but we are working on prototype development now that we would expect to finish by the end of next summer, followed by clinical system integration, followed by animal and human testing. Our team is uniquely positioned to tackle this problem. We have areas of expertise in both clinical and engineering. Thank you all for your time.
Thank you. Great presentation. Do you foresee this being able to be done by primary care physicians, or would this be in the urologist's office?
I think it could be done through primary care physicians. Oftentimes, because of the complaints that are the Clinical situations that then designate the need for a cystoscopy were already involved. But the beauty of this is that it doesn't require a surgically trained provider. I think the current scopes, it requires a fair amount of expertise and experience to manipulate these things, particularly in a male. The urethra is a lot longer. And so if you have this robotic control, an RN or even an MA can manipulate this thing into the bladder. You've got visualization, and that can be sent anywhere to somebody off-site, in another office, that kind of thing. So yeah, theoretically, yes.
So what would it take to actually train somebody to do that? Would a nurse practitioner have to become certified, or would the license need to be revisited so that it would include that one procedure? Like, how long will that take? How much will it cost? That sort of thing.
Sure. So currently, MDs and APPs, nurse practitioners, PAs, can do these. In fact, a lot of offices are utilizing APPs, again, to increase access, but their ability to make treatment decisions is limited. So you can train anybody to do this. We do need to explore the billing ramifications if it's performed by, say, an MA, and the urologist is looking at the images. How does that impact billing? But you're going to find a lot more tumors get patients expedited through care. There's a lot of downstream revenue. So these are all some of the details that we have to sort out. But I mean, you can see in that video, it's pretty easy to manipulate, assuming reasonable looking at it. There's always going to be situations where an MD may have to be pulled in.